Good morning, everyone. Good morning. Welcome to Neurology Grand Rounds. My name is Marydale Baggett, and I am one of the associate editors of the New England Journal of Medicine Case Records of the MGH. And most of you have probably read one of these, but you may not know that they all start off as conferences around MGH. And so we're excited to share with you today a CPC. This case will be discussed by Dr. Christopher Stephen, who will be walking us through a patient that he cared for, but talking with us in depth about his clinical reasoning and his thought process when he was seeing this patient in real time. And I think it'll be a very educational conference for all of us. I certainly learned a lot putting this together. So we're very excited for his teaching today. Dr. Stephen will be joined by Dr. Shaefer, who will go over the relevant imaging, and then Dr. Appelby and Dr. Oakley, who will share with us the diagnostic testing. But first, it's my pleasure to invite Dr. Marina Avetisyan to join us to tell us about this 65-year-old woman with rapidly progressive right arm weakness and falls. I'll turn it over to you.
Okay, awesome, thank you. So this patient's neurologic history actually starts technically at age 6 when she had measles encephalitis that left her with residual severe vision and hearing impairment, mild left-sided weakness. She actually had converted from being left to right-hand dominant, and initial gait and balance problems, which largely resolved with physical therapy and rehab. Then 12 years prior to her admission in her early 50s, she developed some new issues with difficulty with gait and balance. Next slide, please. These progressed somewhat, and 5 to 7 years prior to admission in her early 60s, she was having frequent falls that ultimately prompted neurology evaluation 2 years prior to admission. On that evaluation, she had no weakness, numbness, or paresthesias, no disequilibrium, vertigo, neck or back pain. She had no issues with speech or swallow and no cognitive concerns. Next slide, please. Her exam, this was again 2 years prior to admission, was notable for hypophonia and dysarthria. This was chronic in the setting of her known hearing impairment. She was also noted to have square wave jerk saccades, impaired smooth pursuit, bilateral horizontal nystagmus, globally reduced muscle bulk with normal tone outside of some chronic left finger contractures, and full strength. She did have reduced to absent deep tendon reflexes in arms and legs, and bilateral extensor plantar reflexes. She also had mildly reduced vibratory and proprioception sensation below the knees, and bilateral left greater than right appendicular dysmetria in arms and legs with a wide-based gait and inability to tandem walk and a positive Romberg test. Next slide, please. Diagnostic testing from 2 years prior to admission included an EMG and a nerve conduction study, which were normal, a brain MRI that was normal, an MRI CNT spine, which was also normal outside of just some mild diffuse degenerative disc disease without any significant canal stenosis. She did have CSF analysis 2 years ago with 0 nucleated cells, protein of 15, glucose 63, no oligoclonal bands, and a negative autoimmune and paraneoplastic panel. So normal CSF, essentially. She was treated with physical therapy, and her symptoms with the gait and balance issues did stabilize. Next slide, please. Then 3 months prior to her admission, she developed new subacute right upper extremity weakness that worsened over several months. This manifested as difficulty holding objects, buttoning clothes with her right hand. She actually had to switch back to using her non-dominant left hand for holding utensils and doing other tasks. With this, she had no pain or sensory changes, no issues with speech or swallow, no headaches or muscle spasms, no cognitive complaints, and stable gait and balance difficulties from prior, no changes there. Next slide, please. Her physical examination from 3 months prior to admission was notable for all of her stable prior neurologic deficits, in addition to this new proximal and distal right upper extremity weakness. So she was noted to have a right shoulder drop and decreased 4- out of 5 strength in her right shoulder abduction, 4+ out of 5 in her right elbow flexion, 4 out of 5 elbow extension, wrist extension, and finger abduction. The remainder of her strength exam was normal/stable from her prior presentations. She did have globally reduced tone. An exam was also notable for now having 2+ reflexes in her right biceps. Otherwise, reflexes were reduced to absent as prior. Next slide, please. Diagnostic testing from 3 months prior to admission included another EMG, which this time showed no recorded motor units in her right deltoid or infraspinatus muscles, as well as complex repetitive discharges in her right cervical paraspinals and deltoid muscles. Nerve conduction studies were notable for mild amplitude reductions in bilateral, medial, and right ulnar sensory responses, but were otherwise normal. She had a brain MRI that was reported as normal, and she had an MRI C&T spine that just had stable changes from prior. Next slide, please. So over the next 3 months since she developed the right upper extremity weakness, she had rapid progression of this weakness, which prevented her from effectively using her cane and walker, resulting in recurrent falls and unfortunately inability to care for herself at home, prompting her hospital presentation. So if on her hospital admission, past medical history notable for the measles encephalitis, and then just hypercholesterolemia and hypothyroidism. Her family history was notable for her father died from Creutzfeldt-Jakob disease, which was autopsy confirmed with symptom onset in his 70s and him passing away 8 months later. Her mother also has Alzheimer's disease diagnosed in her 60s, and one of her 4 siblings had an intracerebral hemorrhage. Social history, she lived alone and works for a nonprofit agency. She was a lifelong non-smoker. She drank 4 glasses of wine per week, no illicit drug use. Medications included largely supplements, ascorbic acid, vitamin B complex, coenzyme Q10, vitamin E, calcium, and levothyroxine. She had no known drug allergies. Next slide, please. Next slide, please. Her general physical exam on her admission was notable for essentially a reduced BMI of 15.7 and an overall emaciated appearance with globally reduced muscle bulk. Next slide. And her neurologic exam in the hospital was notable for right upper extremity weakness that had progressed to now being 2 out of 5 strength in her right shoulder shrug, shoulder abduction, elbow flexion and extension, and 3 out of 5 wrist extension and finger flexion and extension. She also had new proximal leg weakness with 4 out of 5 bilateral hip flexion, and reflexes were now 3+ at the right bicep, 2+ at the right brachioradialis, and otherwise was again areflexic. She was also noted to have occasional jerking movements in her left greater than right lower extremities that were thought to be possibly stimulus induced. Diagnostic testing inpatient included labs with a normal CK, B12 folate, and TSH, as well as unremarkable basic labs. She had a repeat brain MRI and whole spine MRI, and additional CSF studies were obtained. You can go ahead and turn it over to radiology.
Great. Hi, I'm Dr. Shaefer. Next slide, please. So these are the MRI images from 2 days after admission. And the top row is the flare, the middle row is the diffusion weighted images. I don't think you can see my pointer, but there's subtle restricted diffusion or DWI hyperintensity in the left motor and sensory strips, and there was some along the left medial frontal lobe. And we could also see some, the bottom row of images are the susceptibility weighted images, and we could see some low signal in those same regions on the susceptibility weighted images. And so we looked back at the original MRI. Next slide, please. And you can see more clearly here on those diffusion weighted images, which is the middle row, restricted diffusion in the left motor and sensory strips, as well as along the left medial frontal lobe. And you can also see subtle associated flare abnormality on the top row and decreased signal on the ADC maps, which confirms restricted diffusion. And so basically, this was noted in retrospect after reviewing the current exam. Next slide, please. So the bottom line is there was restricted diffusion with subtle flare hyperintensity in the cortex of the left frontal and parietal lobes, including the precentral and postcentral gyri on the more recent exam and on the original exam. And then there was near interval resolution of these findings, but there was new linear susceptibility consistent with either hemosiderin deposition or iron deposition in the same cortical regions. So the differential diagnosis for cortical restricted diffusion in general is ischemia, hypoxia, necrotizing encephalitides, seizure-related changes, Creutzfeldt-Jakob disease, hypoglycemia, hepatic encephalopathy, and MELAS. And I'm going to end there and let the discussion begin. Thank you.
Excellent. Thank you very much for that wonderful overview. Next slide, please. So this clearly is a complex case, and my goal today is to tease apart some of these complicated features and to help localize the problem. As the first neurologist to see her after a long interval, it appeared that her long-standing ataxia, albeit appearing to have slightly worsened symptomatically over time, appeared roughly similar on examination to that seen at her assessment 2 years prior, and therefore should be considered separately. However, the more pressing matter is the development of subacute and subsequently rapidly progressive right arm weakness, which later spread to involve her right greater than left legs. This time course is important, as it then indicates the type of processes that can lead to such rapid progression of symptoms and signs. There are several salient features on examination. She has long-standing severe vision and hearing difficulties, but pertinently, there's not been any clear change in her mental status or the development of encephalopathy. Then we look at the pattern of weakness, which we see here, which appears quite diffuse, with an initial flavor of a pyramidal distribution. And then this becomes more noticeable, with extensors clearly more affected than flexors, albeit again with more global involvement, and certainly not corresponding to a peripheral nerve or root distribution. Next slide, please. This also occurs on the background of global atrophy, not clearly more so involving the paretic limbs, and reduced tone throughout. There's also slight reflex asymmetry, which becomes more pronounced in the upper extremities, brisker on the paretic arm, and otherwise globally absent in the legs. There's evidence of a mild peripheral neuropathy, and pertinently, without sensory loss in the distribution of her weakness. Adding to the complexity is the more recent development of jerks involving primarily the right leg, which likely represent myoclonus by their description and are possibly stimulus-induced. This is a very important feature. A particularly pertinent feature as well is that her MRI brain revealed gyriform curvilinear signal changes involving the predominantly left frontal and less so parietal cortices. These changes are compatible with the right-sided symptoms and a very uncommon finding, and helps greatly in directing the diagnostic process. MRI C-spine didn't reveal any cause for a weakness localizing to the spine. Laboratory data was negative for paraneoplastic and common autoimmune neurological diseases, and her CK was not elevated. Finally, her EMG had a pattern of decreased activation throughout, which is suggestive of a central process without features of a peripheral nervous system injury, such as abnormal spontaneous activity or signs of motor unit remodeling, such as increased motor unit potential duration and the like. Next slide, please. I'll now take you through my thought processes regarding the case. The salient clinical features pertinent to the case are shown on the left, and I will go through each of the areas of potential localization in a case of rapidly progressive weakness. I will also list the limited subset of disorders that can cause rapidly progressive weakness at each of these levels, although you have to understand that many of these are not relevant to the case in question. Firstly, we have to consider whether this is a central or a peripheral process. That she has a pyramidal distribution, the development of arm and then leg weakness would be more suggestive of a central process. And the findings on EMG are also compatible with this. Next slide, please. There are no signs that this is a primary muscle disorder, given clear upper motor neuron features, her normal CK, and lack of associated myopathic EMG findings, although it is noted that she has globally reduced muscle bulk. Next slide, please. The lack of any fatigue or weakness, lack of more global or symmetric symptoms, increased reflexes, and the absence of ocular or bulbar weakness would make a neuromuscular junction disorder highly unlikely, and also obviously in the context for imaging. Next slide, please. Next, progressive peripheral nerve and nerve root disorders and more global lower motor neuron conditions are common causes of rapidly progressive weakness, although one could initially have entertained that a process involving the brachial plexus could be responsible by the distribution of her weakness. The potentially lower motor neuron features in her case, those being global atrophy, reduced lower extremity reflexes, low tone, really are long-standing. And the new features are of brisk reflexes occurring in the arms from previously globally reduced reflexes. And there are no neuropathic features on EMG. And again, there are instead clear features pointing towards a more central process. Next slide, please. In a patient with rapidly progressive weakness, consideration of anterior horn cell disease is very important, as amyotrophic lateral sclerosis and primary lateral sclerosis can be rapidly progressive and may have a mixed pattern of weakness. For instance, they can start in a limb and then progress, sometimes involving the ipsilateral side. Also, in some cases, can have a similar rate of progression to that seen in this patient. However, the pyramidal distribution of her weakness and lack of acute or chronic neurogenic features, those being fibrillations, sharp waves, or other chronic changes, no spontaneous activity present, no change in the motor unit action potential, are against ALS or an anterior horn cell disease. Next slide, please. Next, disease at the level of the spinal cord, generally related to compressive, inflammatory, or ischemic insults, in this case involving the right hemicord, is what we would think, that being the case of unilateral weakness, can generally be ruled out by our negative spinal imaging, particularly in the setting of rapid progression. Next slide, please. This then leads us to a localization at the level of the brain. This is expected given the imaging findings which involve diffusion abnormalities in the left frontal and parietal corticeans. Brainstem lesions, even though not evident on imaging, would generally be associated with neighborhood cranial nerve signs and generally more pronounced weakness, often involving the face, where again, more prominent weakness, sometimes involving the entire hemibody with or without sensory loss, can occur in processes involving the internal capsule or thalamus. However, no lesions are present on brain imaging in these areas. Therefore, looking at specific upper motor neuron localization at the level of the motor or premotor cortex must be done in the context of helping to explain the imaging findings. And this significantly limits diagnostic considerations. Such imaging findings are most commonly associated with ischemia, as discussed, whether related to stroke or cerebral venous thrombosis. However, the subacute acute tempo of progression is against this. There was no indication of seizures or hypoxia, which can result in cortical-based changes. An important area of consideration includes infectious diseases causing cerebritis, such as herpes simplex encephalitis, rabies, and others. This group also includes prion diseases, which particularly in the setting of her family history must be considered. However, the lack of cognitive decline or encephalopathy is noted. Also, she doesn't have worsening of her ataxia clearly. There are no metabolic derangements, which can encompass hypoglycemia or liver disease. Other inflammatory conditions such as Measles, which was alluded to in the radiological differential, may appear unlikely. Many of these can be ruled out by her non-imaging investigations, and there's no evidence of stroke or obvious structural lesion, and there are no features of an active infection or elevated CSF protein to suggest an autoimmune disorder, while the absence of encephalopathy would make an autoimmune or infectious encephalitis process less likely, albeit not entirely impossible. Next slide, please. However, this is not the whole story, as we were given more recent information with the presence of new jerking, primarily involving the right paretic leg. and there is suggestion of possibly some stimulus sensitivity or even startle. This is clearly concerning for myoclonus and further adds to our diagnostic complexity, with this now representing a case of rapidly progressive weakness and with a later onset of myoclonus. When dealing with a patient with a suspected myoclonus, one first has to decide whether this is cortical or subcortical in origin. Myoclonus can be present in several degenerative conditions, including the myoclonic epilepsies or cortical basal syndrome, as well as other cerebral, as after cerebral ischemia or hypoxia, classical Lance-Adams syndrome, as described by Ray Adams, and several immunological conditions such as obscurus myoclonus syndrome. The differential diagnosis of myoclonus by localization is described nicely by Espay, and I'll use this schematic as a model. Next slide, please. Subcortical myoclonus originates between the cortex and the spinal cord and is typically bilateral and maybe global in distribution. There are no features to suggest a brainstem origin. She's not on any medication cortical myoclonus, nor any significant toxic exposures or metabolic features that could account for this. Her imaging, which is cortically based, is instead suggestive of a cortical myoclonus. Next slide, please. Cortical myoclonus is caused by intrinsic cortical hyperexcitability, which may be focal, segmental, or multifocal. Although more generally prominently involving the hands and face, in this case, cortical myoclonus is favored as it occurred in the paretic limb and appeared to be stimulus sensitive and in the context of imaging involving the cortex. She does not have an associated epilepsy or encephalopathy, and the progression is too fast for one of the myoclonic epilepsy syndromes. Next slide, please. She also has no metabolic cause identified, which would generally produce a generalized myoclonus and would not be associated with the unilateral, at least initially, weakness that she had. Next slide, please. Infectious, parainfectious, or paraneoplastic encephalopathies would be unlikely and also typically associated with encephalopathy, which is not present and generally not associated with unilateral weakness, or if present, related to some identifiable brain lesion. Next slide, please. Her progression has been rapid, and there are no signs of a slowly progressive neurodegenerative condition. This is much faster than would be seen in cortical basal syndrome and would also not be associated with similar weakness, which is a principal sign of examination. And in comparison, cortical basal syndrome often presents with sometimes strikingly unilateral dystonia, frequently associated with myoclonus and cortical sensory loss in initially the affected limb. Next slide, please. We are then left with the category of dementia associated with cortical myoclonus. And while she does not have features of progressive cognitive impairment, it is at this point that we must consider the unusual nature of her presentation, associated rapid progression, as none of these tend to occur with rapidly progressive weakness in a similar manner. We also have to take into account her family history of Creutzfeldt-Jakob disease, a rapidly progressive disorder typically associated with the development of dementia, ataxia, and myoclonus, inexorably progressing to akinetic mutism and death. While we do not know what symptoms her father had, and given that CGD is typically an idiopathic disorder, it is important to acknowledge that genetic forms of CJD do exist and present in an autosomal dominant manner, which would be compatible with inheritance from her father. This would also be compatible with the cortical ribboning seen on imaging, which is an ominous sign in general and highly concerning for prion disease. It is notable that other prion disorders, such as Gerstmann-Streusler-Schenker syndrome, can present with a neuromuscular phenotype, albeit with slow progression. Of these, the rapidity of presentation and that her father had autopsy confirmed CJD, which would not be confused with one of the other inherited prionopathies, GSS, Gerstmann-Streusler-Schenker, and fatal familial insomnia, which progressed much slower and instead could specifically indicate a genetic form of CJD. While it's not completely out of the question to have two family members both developing sporadic CJD, the chances of this would be extraordinarily low. Next slide.
Okay, so I'll discuss some diagnostic tests that were performed and their interpretation. Next slide, please. So a lumbar puncture was performed. In CSF, there was no evidence of pleocytosis or any malignant cells. CSF tau protein was below the reference range that's used to indicate positive for CJD. 1433 protein was negative. However, the CSF RT quick was positive. Next slide, please. And so these tests are interpreted using the CDC's diagnostic criteria for CJD. A patient can fall into one of three categories, basically, either someone with definitive CJD, probable CJD, or possible CJD. A definitive diagnosis requires tissue. So it requires a standard neuropathological examination showing spongiosis and cortex, immunohistochemistry showing prion protein aggregation, or Western blot or other demonstration of PRP fibril formation. So that's not an option so far in our patient here, but the patient may fit into the probable category. And so to diagnose someone with probable CJD is required a neuropsychiatric disorder plus a positive RT quick in the CSF or other tissues. And so that's the category that this patient fits into at this point. A probable diagnosis can also be arrived at in someone with a rapidly progressive dementia that looks like CJD clinically and has another confirmatory laboratory test, including EEG 1433 protein or MRI. And possible diagnosis, CJD can be diagnosed in someone who clinically appears to have CJD, but doesn't yet have a positive study. Next slide, please. So this test was interpreted as consistent with probable prion disease of greater than 98% likelihood, and the Prion Center at this point offered a no-cost autopsy to confirm the diagnosis.
Okay, so pertinent to this case, we also had some further history. Next slide, please. So after the results of the CJD testing heightened suspicion for familial CJD, additional history was obtained from the patient's sister, who was not present or with contact information available during the initial assessments. And it appeared that the patient's uncle, the patient's father's fraternal twin, also died of CJD. That both fraternal twins were affected is consistent with hereditary CJD. What's also very interesting is that there are striking similarities in the initial presentations of the patient and her relatives, although in her father and uncle, more typical features of CJD are present later in the course. Next slide, please. So here we have some further history from the uncle. So he presented at the age of 59 with left-hand sensory symptoms, which were initially misdiagnosed as carpal tunnel syndrome, which seems reasonable. However, he then developed rapidly progressive left-hand weakness, followed by right leg weakness and slurred speech. At that point, initial lumbar puncture and EMG were normal. Then 3 months after the onset of hand symptoms, he developed spasticity and hyperreflexia, vibration and proprioception sensory loss, and ataxia in the arms and legs, along with some cervical dystonia and worsening of his dysarthria. He was admitted under the care of Dr. C. Miller Fisher, and we see here his discharge documentation here on the right. So he later developed myoclonic jerks of the arms and legs and decreased responsiveness. EEG showed characteristic features of CJD with generalized slowing and disorganization with infrequent spike wave complexes, which were felt clearly compatible with CJD. During that time, he was trialing some experimental treatments, including amantadine and then even AZT or AZT, but none of them produced any symptomatic benefit. He then died 4 months after the onset of his hand symptoms. An autopsy confirmed CJD. Next slide, please. We then have further history from his father, who presented at the age of 71 with right hand weakness. Now, further complicating this was the fact that his symptoms occurred in the setting of a lung cancer diagnosis, and he actually underwent surgery for his lung cancer, which involved the left lower lobe, in case this was some kind of paraneoplastic condition. However, this did not result in any improvement in his symptoms, and instead he had rapid progression. He developed right leg and facial weakness, and then later slurred speech and mild dysphagia. He developed brisk reflexes and temperature and vibration sensory loss in the legs and some right side ataxia. MRI brain at this point was unrevealing, and his LP was normal. EMG revealed evidence of an axonal motor neuropathy. He was admitted in this time to the Brigham and Women's Hospital under the care of Dr. Walter Korschetz, who is now director of the NINDS. During that time, he had an EEG which was consistent with marked bihemispheric dysfunction and cortical irritability, and repeat LP was unremarkable. Pertinently, and similar to the patient described in this case, his CSF 14-3 also tested negative. Repeat MRI brain revealed vague cortical rimming on DWI and symmetric medial temporal lobe atrophy. Unfortunately, he died 7 months after the onset of his weakness. And again, autopsy confirmed CJD. Next slide, please. So therefore, my diagnosis, given the presence of 2 family members who were fraternal twins, both having had CJD, that this almost certainly represented a familial form of CJD. Therefore, in light of this family history, I contacted Dr. Brian Appelby, who I had known when I diagnosed another patient with another familial prion disease, in this case, Gerstmann-Straussler-Schenker, for sequencing of the prion protein gene to the National Prion Disease Pathology Surveillance Center. Next slide, please. So prior to doing that, I performed a literature review, and from my experience from having my patient with GSS, I found that there can be cases, which have also been seen at the MGH Ataxia Center, where there can be a neuromuscular phenotype of Gerstmann-Straussler-Schenker syndrome. Next slide, please. And you see here, this forms one of the symptom clusters which they tried to form 4 different phenotypes of GSS, that being this, in this case number 2, the GSS with areflexia and paresthesias, which can also develop weakness and evidence of neuropathic features and are generally areflexic. Next slide, please. And so therefore, on further literature review, I found that there are exceedingly rare cases of monoparesis as a presentation of familial CJD, such as in this paper here by Cohen and colleagues, where only 1 of 77 patients had this phenotype and was reported as a particularly unusual presentation. Next slide, please. And we see here the presentation as progressive monoparesis. The case they described developed right leg weakness and some sensory symptoms and pain. He had, in this case, evidence of a sensory motor axonal polyneuropathy with normal EMG, and then developed more classical features suggestive of CJD after the development of progressive upper and lower extremity weakness, with the development of ataxia, becoming wheelchair bound, and then succumbing to symptoms. Next slide, please.
Okay, next slide, please. So as was said before, the vast majority of cases of prion disease are actually sporadic or idiopathic, about 85%. And the least common forms of prion disease are actually the acquired forms, Kuru, iatrogenic CJD, or variant CJD. So the remainder are what we call the genetic prion diseases. And they're named based on different clinical neuropathologic phenotypes, as well as the different mutations affected. And they can be named such as genetic CJD, Gerstmann-Straussler-Schenker syndrome, or fatal familial insomnia. So all genetic prion diseases are caused by a genetic mutation of the prion protein gene. And it's thought that that makes it more likely to misfold into the pathologic isoform that causes prion disease. So in this figure, you'll see the top labels, which are red, which are pathogenic mutations. And you'll see our patients circled E200K. Underneath of that are several polymorphisms that we know sometimes can affect, slightly affect likelihood of iatrogenic, variant, and sporadic CJD, but more pertinent to a case like this, it also affects clinical phenotype. And the one that we most commonly reference is codon 129, in which you can be homozygous for methionine, valine, or heterozygous. So in this case, the patient had the E200K mutation that was in cis with methionine at 129. And in trans, she also had methionine. Her uncle, I don't think her father actually had genetic testing, but her uncle did, of course, also had the same haplotype of E200K and methionine at 129 in cis with the mutation, but had valine in trans. Next slide, please. So E200K is the most common mutation that causes genetic prion disease worldwide, as well as within the US. So in the US, about 60% of genetic CJD is caused by this mutation. And as you would expect by the name, it actually closely resembles clinically and neuropathologically what we would refer to as a Creutzfeldt-Jakob disease phenotype. The mean age of onset tends to be mid to late life, with a mean age of about 61 years. But as you can see, there's a lot of variability. And in fact, not all people who develop or who carry the E200K mutation develop prion disease during their lifetime. And we'll talk about that later. Much like Creutzfeldt-Jakob disease of sporadic etiology, the duration typically is quite quick, of about 4 months of median duration. But again, there can be quite a bit of variability. Clinical presentation also resembles sporadic CJD, typically with dementia, gait disturbance, behavioral changes. We do occasionally see neuromuscular presentations that most commonly occurs in GSS, as we've heard before, but probably it's next most frequent in the E200K mutations. And then the diagnostic tests that we use to diagnose sporadic CJD are frequently positive in E200K mutations, for example, the RT-QuIC test, as well as the brain MRI findings. Next slide, please.
Okay. Excellent. So we also have some follow-up from the case. So the patient was discharged to a rehabilitation facility, and unfortunately she had an inexorable progression of her weakness, which progressed to flaccid paralysis of her right arm. Her dysarthria worsened and developed frequent myoclonus in both legs. She became bedbound and required assistance to sit. Genetic test results of her father and uncle were discussed with the family, and given the similar presentation with arm weakness rapidly progressing to ataxia and myoclonus, there was a high suspicion for familial CJD with a similar mutation. After discussion with her family, goals of care were changed to comfort measures. She sadly died 5 months after the onset of her right arm weakness.
Okay, I'm going to discuss the autopsy findings, and I will try to share my screen so I can use a pointer. Let's see. Okay, I hope that you can see that. Okay, so an autopsy, the patient did pass away and an autopsy was performed. On gross examination, there was some mild frontal atrophy in the brain, but otherwise unremarkable cut sections. And unfortunately, I don't have photographs of the external surface of the brain or the cut sections because these kind of autopsies are performed under enhanced infectious protective procedures. So we don't usually take photographs, but I do have some photographs of the microscopic tissue. Let me try to advance the slide. Okay, great. So here I'm showing in the top row some examples of areas of neocortex throughout the brain, and in the bottom row, basal ganglia, thalamus, and cerebellum, so the deep gray structures in cerebellum. And let's start by looking at the cingulate gyrus here at a moderately high power on an H&E stain. This is an area of cortex. We have pyramidal neurons, astrocytes, and oligodendrocytes. And so just looking at the cytoarchitecture of this piece of cortex, most of the neuronal subclasses are preserved. There's a little bit of gliosis in here, but the major finding on this piece of cortex is that the neuropil, the background neuropil, should be a homogeneous pink, and it's really quite spongiotic here. All of these very small circular holes are spongiosis, and this was present in all cortical layers. So it's a transcortical spongiosis, not isolated to layer 2, as you see in some neurodegenerative diseases. And importantly, it's different from the spongiosis or the tissue holes, which are artifacts that appear around blood vessels here and adjacent to some of the neurons. The other thing that helps somebody make a diagnosis in this kind of a case is that some of the spongiosis shown here goes all the way through the tissue, and other points you can see it only goes partially through the sampled area of tissue. A similar spongiosis was present in the middle frontal cortex here, although slightly to a little bit lesser degree, where you have some vacuoles going all the way through the tissue and others occupying only a portion of the tissue. Here, a little bit more of that tissue artifact related to just processing or acute hypoxic damage around the neurons, but this is not the spongiosis of CJD. In the background here, we see these kind of spongiotic areas are what we're looking for in pathology. We did sample the periorlandic cortex given the MRI findings and found that it also had a moderate spongiosis in the neuropil and a moderate gliosis as well. Deep gray nuclei showed similar pathology. So this is a section of caudate. We have a white matter tract here, and here these are the pencil fibers of Wilson, full of oligodendrocytes, and the background neuropil here in the caudate should be again a homogeneous pink, but it's really moderately spongiotic. Thalamus, we have similar findings, a little bit more advanced spongiosis here and a moderate gliosis in the background of the thalamus. And then the same is true for cerebellum. The granule cell layer and the Purkinje cells are essentially normal in appearance, but the molecular layer, which should be basically an almost acellular layer of neuropil, is no longer this homogeneous pink that it should be, and there's quite a bit of spongiosis throughout that neuropil. So these findings taken together are diagnostic of CJD, and the distribution and severity of them would be consistent with a patient with this E200K mutation and a 129 methionine. So there's one more finding that I want to share from the autopsy, and that concerns the visual system. So this is a low power view of the lateral geniculate nucleus on a Luxel H&E stain. So white matter tracts are blue here, and then the LGN, shaped like Napoleon's hat, is a sort of a pink color. This is the place in the brain where the first synapses come in from the eye. So retinal ganglion cells come in and they synapse in the LGN. And what should be here are 6 layers of cells having synapses from both eyes coming in, 2 magnocellular layers and then 4 parvocellular layers coming up throughout the LGN here. But in a sense, you have to take my word for it, but you should be able to see them at this magnification. And all we can see is a very small population of neurons here. And the rest of the LGN is essentially devoid of neurons. So a little bit higher power, and now we've removed the Luxel stain. We're just looking at an H&E stain in the LGN. We can see that there's a really severe depletion of neurons and a moderate to severe gliosis. These are reactive astrocytes here in the LGN. And one thing we don't notice in this part of the brain is spongiosis, right? So these aren't the changes that we would expect to see in CJD. This is something else. And so this is related to the patient's history of a measles encephalitis. I guess it's 6 years old, right? And would be the anatomic substrate for her basically cortical blindness or central blindness, I guess. If we go one synapse further in the visual pathway, we can go to primary visual cortex. And here we see essentially a normal complement of pyramidal neurons. But again, we see the spongiosis of CJD in the background. So this part of the brain is affected by CJD and not so much by degenerative changes secondary to the childhood history of encephalitis. So to summarize the autopsy, we found moderate spongiosis and gliosis of the cortical and subcortical regions. And that's consistent with the diagnosis of CJD. There was gliosis and neuronal loss in the LGN consistent with history of measles encephalitis and subsequent blindness. And things that I didn't show you, there was some very minimal tau deposition in the medial temporal lobe and pons, not significant in this case, and some moderate cerebrovascular disease. So on cases with prion disease, we do send fixed and frozen tissue to the National Prion Disease Surveillance Center, and they performed a Western blot analysis on the frozen tissue there and showed that there was the presence of abnormal protease resistant prion protein, confirming the diagnosis of prion disease. So the final neuropathologic diagnosis is familial Creutzfeldt-Jakob disease.
Next slide. So when these results became available, the family had questions about the implications for them. Dr. Appelby will speak about genetic counseling and further directions in this complex genetic disorder, where patients are asymptomatic until they develop symptoms, when there is then rapid and inexorable progression and is universally fatal, presenting an ethical conundrum.
Next slide, please. So obviously, this is a very touchy subject because we're dealing with a genetic disease that does not have a treatment that appears later in life. It's important to know that genetic testing can be done one of 2 ways. You've heard about how it can be done at autopsy on brain tissue, but we can also do genetic testing on blood as well. And of course, we're testing for mutations of the prion protein gene. We strongly recommend for any asymptomatic counseling, and even sometimes for symptomatic counseling, that genetic counseling is involved so that people understand what it means to have genetic disease as well as the specific genetic disease. And for that, we follow what is typically referred to as the Huntington's protocol, which is used for asymptomatic testing for the Huntington's gene. We find that there are a lot of overlaps with other neurodegenerative conditions, and I refer you to that protocol for more details. It's important to know that because of the Prion Center, they do have a little unique situation in that they have 3 options. Of course, they can choose not to get tested and not know the results, or they can choose to get tested and not know the results. They can choose to get tested and know the results, or what we see in probably about 1/5 of the time is that they can get tested and that we can hold the results for them. And the reason why they do that is because it's not uncommon, especially for cases of GSS or other diseases, where it may not be known that there's a family history. There's been question about whether or not it is a genetic illness. The person themselves do not want to know whether or not they have the mutation. But if something were to happen to them, they want their progeny to be able to find out whether or not they're at risk of inheriting the mutation. So in that instance, they would do the genetic testing and the Prion Center would hold the results. They themselves can request the results at a later date, or the legal next of kin can, should the patient pass. As was mentioned before, genetic prion disease is always an autosomal dominant inheritance, and penetrance, which is the likelihood of developing the disease if you carry the mutation, approaches 100%, but is not exactly 100%. We definitely see an age-associated penetrance. We do occasionally see people that carry the mutation that don't develop the disease. But again, the older a patient gets who carries the mutation, it's much more likely that they will develop the disease. And penetrance is a very important topic, to discuss with genetic counseling, because it's important to note that not all genetic prion disease have equal penetrance. There are some genetic prion diseases that have almost 100% penetrance, such as fatal familial insomnia and Gershman-Stressler-Schenker syndrome. There are some genetic CJD mutations that have very low penetrance, 1% to 10%. And then there's E200K, which of course is close to 100% and is age-related. Next slide. So one may ask, well, why would you want to know whether or not you carry a mutation for a fatal neurodegenerative illness without a treatment? And nowadays, there's multiple discussions to have on that. And one of them is pre-implantation genetic diagnosis using in vitro fertilization. And this process basically involves doing IVF, testing the embryos for the genetic mutation, and only implanting the embryos that do not have the mutation. This is extremely powerful for the family because they can essentially eliminate the disease from the family by doing this. And they can have biologic children and not have to worry about them carrying the mutation. Interestingly enough, pre-implantation genetic diagnosis can also be done even if the parent does not wish to know what their genetic status is. Next slide, please. And the other very real possibility for why people may want to actually know their mutation status is the, I think, very optimistic likelihood for genetic therapies in genetic prion disease. We know that you actually need the normal prion protein to have prion disease. So for example, if you knock out the prion protein in mice and you inoculate them with prions, they don't develop the disease. So it is necessary to produce normal prion protein. And of course, if someone has a genetic mutation, they're producing an abnormal isoform that's more likely to convert into the disease-associated isoform and cause the disease. So theoretically, if you could, downregulate or knock out the prion protein, you could potentially eliminate the disease or prevent it or delay it from occurring. So that's the whole thought about these new genetic therapies coming out, is perhaps PRNP, the gene for prion disease, could be effectively targeted and reduced its expression so that that could potentially be a treatment for symptomatic prion disease, but perhaps more importantly, in asymptomatic people who carry the mutation, and the potential to delay or maybe even prevent onset of the disease before it even starts. And of course, I think this is a rationale for asymptomatic genetic testing, and that should be discussed, as it has been public that there are some companies that plan on doing clinical trials using this approach. Next slide, please.
just one additional point pertinent to the pathology findings regarding the primary visual cortex. The patient did, prior to her death, note that her vision had worsened such that she had great difficulty seeing the signing from the sign language interpreter. So that suggests that CJD did play a role in terms of her vision at the end of her life.
I just want to say thank you to all of our discussants who participated in the case today. It was a really wonderful learning experience. We do have time for questions. I have one question in the chat. Other participants, if you have questions, please put them into the chat. We'll try to get to as many as we can. Our first question is from Dr. Linola. She actually saw this patient early on in her course, said it's fascinating to see what the outcome was. She raised the question if the early ataxia that the patient experienced was related to her CJD. Dr. Stephen, I know you thought about that a bit. Would you like to take that question?
So I think in this specific case with someone who's legally blind and deaf, I think communication was challenging in this case. Also, and this involved even just setting up the testing and various things like that, let alone just communicating in the setting of a medical situation. So I think whether there could have been some kind of cognitive impairment, I think it was difficult to know. We know that in her, there was some element of dementia going on at the very late stages, just before death. But as we've seen in the case that I discussed from Cohen, the main feature of this was rapidly progressive weakness. And so, I think that the dementia component was more of a minor feature. Also, what makes this case very challenging is the fact that she had this ataxia that seemed to kind of slowly progress over time later on in age. Now, while it's impossible to say definitively that this ataxia wasn't related to her abnormal prion gene, my feeling is that it's likely unrelated, given the fact that none of her family members who harbored the same mutation had this, until rapid progression at the very end stages of their disease. And the very slow progression, may be more compatible with age-related changes in someone who has an abnormal brain. However, the presence of this abnormal prion protein, maybe it accelerated that process somewhat. But I would think that it was probably unrelated, as I said, mainly given how closely linked the presentations of her family members were, but without having, the slow progression over many, many, many years. I'd be interested to see what Brian thinks of that.
Yeah, I mean, I think it's extremely difficult. And obviously you saw the patient, but I would argue that because of the slow progression, it likely wasn't part of her CJD phenotype, the ataxia. So.
Thank you. We have another question here from Dr. Rosenberger. He brings up that she had childhood history of measles and wonders if there was consideration of SSPE.
So we don't have the records when she was a child. And some of the difficulties in this case, for instance, the fact that we didn't know that her both father and uncle had CJD was the fact that she didn't list her sister or other family members as contacts, and the only number we had was for her. So she wasn't able to provide a lot of history about what happened when she was very, very young. Could this have been SSPE? Certainly, but that wouldn't have caused what she felt, that being kind of a slow progression over over 5 years. I think that would be highly unlikely to be associated with this kind of slow progression. And when you have someone that has a balance disorder, if you are having worsening of your vision over time, of course that can contribute to that. And what I would say is that what's also pertinent is that the ataxia on examination, from my examination when she'd already had weakness for a month, was really pretty similar to what was described by Dr. Linoya, 2 years prior. So, you know, as I said, I think that we have to consider the slowly progressive, you know, ataxia to be a bit separate from the rest of her acute onset symptoms, which would be more compatible with the rapid progression seen in CJD.
Thank you. Any other questions from the audience? Always lovely to end early and give people 5 minutes back in their day. Okay, so if there are no other questions, then we'll go ahead and wrap up. Once again, thank you very much to all of our discussants. We really appreciate your time this morning. Keep an eye out for this. Hopefully you'll see this in the next couple of months, published in the New England Journal. Thank you all very much.
Thank you.
Thanks.